All right, so today we'll talk about shock as part of our sepsis month. So we'll talk about specifically kind of some of the stuff we do to treat septic shock. Okay. So the first thing we do is figure out kind of what constitutes a shock. Okay, so specifically in the setting of sepsis, we use this definition of hypotension. Okay, so whether that be, typically in the ICU we use a MAP. So a MAP, or mean arterial pressure, less than 65. Or if you want to use a systolic blood pressure, less than 90. Okay. Usually both those things are seen. However, depending on if you have an A line or kind of what your diastolic pressure is, you might look at one more than the other. Okay. So hypotension despite IV fluids. A lot of times they'll include like a 2-liter IV fluid bolus. However, updated sepsis guidelines do recommend we call specific like patient-directed IV fluid. So we'll say 30 cc's per kilogram IV fluid bolus, which again, our average patient we say is like 70 kilos. So that's about 2.1 liters, right? So about 2 liters, but again, it really depends on your patient. So if your patient's 100 kilos, then they should be getting 3 liters. And again, this is, sometimes we're able to give this safely to patients and sometimes we're not. So if the patient has heart failure or renal or like kidney failure and has already a bunch of fluid on them, they probably won't tolerate 2 liters. So if they're already in, especially if they're coming in with a pneumonia or something, so if they're already in respiratory distress, you might not be able to give them 2 liters safely, in which case you would have to start other medications sooner. On the flip side, there are patients, if your source is like a diarrhea or maybe you have like a bad like UTI or kidney infection, and so you're drinking lots of water, and then you're just like, I don't know, peeing it out or whatever. Or if you're having a lot of vomiting, you might be dehydrated, so you might get your initial fluid bolus and still need more fluids because your volume down. Okay, so the way that so there's kind of 2 things I want to talk about. One is how to help differentiate the people who need a different amount than the 30 cc's per kilogram. So that's a concept we call fluid responsiveness. And that's essentially, if I give you more IV fluids, will you respond? Okay, so, and by respond, I mean, will your blood pressure get better? Will your tachycardia get better? Or will it not do anything? Or potentially make things worse, okay? So there's a few like tips and tricks that we do. For fluid responsiveness, okay. And then also this IV fluids, it's typically what we call balanced crystalloid, so it should be LR, and if not LR, then NS. But LR is the preferred IV fluid, just for the record. Responsiveness. Okay, so there's a few different things we can do to check if we think someone's going to respond to fluids. Okay, so the thing we probably do most often in this ICU is ultrasound or point of care ultrasound. So we abbreviate that POCUS. So you see both of us, but especially the other doctor loves the ultrasound, right? So we can take a look at the IVC. So if your IVC is less than 2 centimeters and is collapsible, which means if I apply pressure, it smushes by more than 30%, more than 50%, or has respiratory variation, which means when they're taking a breath in if they're not intubated, or a breath out if they are intubated, then I see a variation in the diameter by more than 30%. Respiratory variation. Then that tells me that that pipe is not as full as it can be. Does that make sense? So that means you can give them more fluid. So that might be a sign that you can try more fluid. Now, if their IVC is greater than 2.2 centimeters, not collapsible, without respiratory variation, then that's a sign that they're unlikely to respond to fluids, okay? So there is, or I think it's maybe greater than 2.5 centimeters. So there is a gray zone, so there is some in between. So there's sometimes we have someone where, hey, their IVC is maybe like 2.2 centimeters. There's minimal respiratory variation, but it is collapsible. So sometimes I do still try a small fluid bolus to see if it'll help. Okay, so this is the main one we use in RICU. But you can do additional things. So we technically do have a Vigileo, or a non-invasive cardiac output monitor. So that is something else you can use. I'll abbreviate that as a NICOM. But sometimes people will call it by the brand you have. So we have a Vigileo or a Flow Track, whatever. Those are kind of all the same thing. Those typically require arterial access, so an A-line. And so you can set that up and see it when you give fluids, if you have an improvement in cardiac output, a reduction in SVR, or you know, whatever, to see if your hemodynamics improve. You can also, I guess you could also have a actual cardiac output monitor, so that would be like a PA catheter or a Swan. We don't use those here at our hospital. We're talking about getting them here. I don't know how I feel about that, but that would be another way you could monitor the response to IV fluids. We use a lactate, so that's another thing too. If your lactate is clearing, then that's probably a sign that you're kind of reaching eubulimia. You can also do like a passive leg raise. So in your legs, you hold somewhere between 250 and 500 milliliters, depending on your size. So if you raise someone's legs up, which you do if someone like passes out, right? So it kind of makes sense. You're essentially artificially giving them a fluid bolus. So you can see if that improves their blood pressure and tachycardia, and if it does, then they would probably do better with, or they would probably benefit from additional fluids. Okay, sometimes you can look for like a respiratory variation, or kind of stroke volume variation. This is often seen if someone is intubated, so if they're not intubated, you can't really use it, but essentially you're looking at, you kind of line up your ventilator to your vital signs monitor and kind of see, hey, when the patient is getting breaths, are they having incremental improvements in either their MAP or their heart rate? Or are we seeing kind of changes in the volumes that are getting administered? Which again would be a sign, if there is respiratory variation or stroke volume variation, that's another sign that they may benefit from additional fluids. And then sometimes if you're unsure, you can always just give them a small bolus, something like 250 or maybe 500 milliliters, and see if they improve. And then if they don't improve, then you realize you've reached your ceiling, and then you move on to pressors. Okay, so I'll kind of rotate this around. Any questions on fluid responsiveness? Okay, so now that you've decided your patient is no longer so you should use fluids until they're no longer fluid responsive. Okay, sometimes they get up here, sometimes if they've been up here for a few days, they may become fluid responsive again, if that makes sense. if they're not getting like maintenance fluids, or maybe their maintenance fluids are insufficient. Okay, so we might try it again after they got up in the ICU, but that's something that they initially should take care of in the ER. All right, so pressors. All right, so we call them pressors, but technically they're vasopressors. Okay, so vasopressor, compression, so these are medications that will increase your blood pressure. All right, I like to think of them on kind of this like 2x2 grid. So this is vasopressor, and this is or maybe vasoconstriction, I should say. Vasoconstriction, and then this is like vasodilation down here. And then on this axis, we have something called ionotropy, which is a fancy name for increasing kind of the heart squeeze. Okay. And then if you want to think about this, this would be like cardiac, like relaxation. Okay. All right. Questions about kind of how this grid is set up. Okay. So, in septic shock, compared to depending on the type of shock, depends on kind of what pressor you will reach for first, or I guess which ones are kind of first line, second line. So for sepsis, do you guys know what your first line pressor is? Norepinephrine. Yes. Okay, so norepinephrine has a decent amount of vasoconstriction, but also some ionotropy. So I'm going to kind of put it here. So it gets an N for norepinephrine. Okay. All right, so, and then our second line pressor is vasopressin. So I'd put vasopressin like here. So vasopressin is pretty much a pure vasoconstrictor. It does work somewhat differently. So it works on the V1, 2, and 3 receptors mainly in the kidney, versus norepinephrine, epinephrine, dopamine, dobutamine. Most of the other ones will work on your alpha and beta adrenergic receptors, i.e. like your fight or flight response. Okay, so norepinephrine, if you want to think about it like that, in some countries they call it noradrenaline. So if you want to think about it like adrenaline, getting you all riled up. So that's how it works. So it'll increase your blood pressure. It'll also typically increase your heart rate. It will preferentially send blood to your vital organs and away from less vital organs. So some of the side effects and toxicities from norepinephrine, which are similar to the other ones, you can see tachyarrhythmias. So it will increase your risk for things like AFib, VTAC, and then also it'll increase potentially peripheral ischemia. So that's when you can kind of start seeing some of the black fingers, toes, stuff like that. That increases with the dose and time. It can also be irritating to the blood vessels, which is why at moderate and high doses we tend to put it through a central line. However, there's more and more data that you can do, low dose peripheral pressors for 24 hours or so, 24, 48 hours. Okay, so some of the additional pressors we'll go over quickly. So these are kind of your first two lines. And then your next one's probably going to be epinephrine. So epinephrine is kind of interesting because it changes based on if it's high or low dose. So if you're low dose epi, you get comparatively much more ionotropic effect. And then if you increase your dose, you maybe don't get too much more ionotropic effect. maybe a little bit, but you get more blood pressure effect. So if you're trying to treat someone purely for blood pressure, you often need a decent slug of epi to kind of start making an improvement on your map. We'll talk about, I guess, phenylephrine. So phenylephrine or neosynephrine. So that one is also similar to vasopressin, is a pure vasoconstriction. It doesn't really affect your heart at all. It'll really just clamp down your blood vessels. I don't use this very often. It's very commonly used in the OR, and it makes sense because in the OR you're usually just trying to combat the sedation. So sedation-related vasoplegia, whatever. So sedation will vasodilate. So to combat that, a lot of times they'll give pure vasoconstriction or phenylephrine. And that's often because the patients have already been screened and either don't have a cardiac history or they got kind of a cardiac workup before surgery. Okay. Versus our patients are intrinsically very sick. So it doesn't really work as well for us. There is some thought that if you have someone with tachyarrhythmias, that phenylephrine may be better because it has less tachycardia. You can get some bradycardia, if anything, but you usually don't get your tachyarrhythmia complications. So that might be a time I use it. Or if the patient's already on like 4 medications. Questions, or are we just hanging out? All right. Then the last one, which is a drug I don't love using, is dopamine. So dopamine is kind of like epinephrine in that it depends on kind of your dose you're using. So it's probably about here and here. Dopamine low, dopamine high, we'll say. So it doesn't get as much ionotropy as epinephrine, and then when you increase the dose, it doesn't really get you anything more on the ionotropic axis. It really just helps improve your blood pressure. But because of this, it's now considered almost like a dirty drug because it does hit a few different receptors, but you get a variable response. And so often we don't use it anymore. There are some head-to-head trials, specifically in sepsis, that show that norepinephrine and vasopressin are like superior to dopamine. So that's why, at least for sepsis, and so in a lot of medical ICUs, dopamine's fallen out of favor. But it still can very much be used for cardiogenic shock and some other obstructive shocks and stuff. Okay, and then we don't often use these in sepsis, but if someone comes in with septic shock and has mixed shock because they already have heart failure or whatever, just to kind of complete our graph, I'm going to put them in. So down here are 2 medications. So I'll say this is, we'll call it DB for dobutamine. And then milrinone's maybe about here, let's say. Maybe we'll put milrinone. Maybe it's probably better than dopamine, so maybe we'll put it here. Milrinone. So milrinone and dobutamine. So both of them are ionotropic medications, which means they help the heart squeeze and pump. We typically think of these medications for cardiogenic shock. But if, again, your patient has mixed shock or, I don't know, has then acquired septic cardiomyopathy or something, and you think that they need more kind of cardiac output, either because that's what your flow track is telling you, that's what your ultrasound exam is telling you, or I don't know, you have other evidence to support that, you can try one of these medications. So dobutamine is a pure, what we call beta-1, which means it really should only work on the heart. So it doesn't really do too much on the alpha receptors, so that it doesn't do a ton of vasoconstriction. Okay, so if anything, it causes vasodilation. So you may see that when you start someone on dobutamine, their blood pressure drops. That concept is usually more profound with milrinone. Milrinone has more vasodilatory properties. However, if your patient has like pure cardiogenic shock, or what you're trying to do is treat cardiogenic shock or mixed shock, including a cardiogenic component, that you might see that drop at first as those blood vessels expand, but as you improve the cardiac output, that blood pressure should improve. So usually it'll drop and then it kind of improves. Okay. The other things, just to kind of, I don't know, they help me like think about this concept. So we don't use it a ton on our unit, but there's a oral medication called midodrine. Ooh, I'll put this as MD, I guess, midodrine. So some people will take that with, if they have like liver failure and they just always have low blood pressure, or if they have kidney failure, they might take it on like days with dialysis. I've worked in some places where you might try and transition people off pressors to oral midodrine if you think that they may just have long-standing low blood pressure or something like that. And then something that would be like in this category, these would be like your beta blockers. Okay, so when you're like, what would actually relax the heart? Well, it'd be like a beta blocker. And then something that would be like the opposite of your phenylephrine would be like a nitro, like nitroglycerin. So they're very potent vasodilators. Okay, so just to kind of help you kind of think about maybe these medications as opposites, I think helps kind of keep them all in my brain. Questions on kind of pressors, and so specifically for septic shock, there is the best and most evidence for norepinephrine. For pretty much any type of shock, in doubt, I always start with norepinephrine. It works for most shock, and that's because it is a combination of vasoconstriction and inotropic properties. And then as you get more information, you may then transition. So, for example, our patient on Monday, we started norepinephrine, but after looking at her ultrasound and kind of seeing how she was responding, we transitioned her to an epi drip because I think she needed more inotropic assistance. And then the best data for your second pressor is going to be your vasopressin. And then for a third pressor, I kind of just look at my ultrasound. If they have either a history of CHF or their EF looks reduced, I'll often do epinephrine as my third pressor, versus if they have VTAC or don't have cardiac issues or something, but maybe are just significantly tachycardic, I might use phenylephrine. All right. Questions? Whirlwind on the pressors. You look like you want to ask something. Do you want me to? Okay. All right. Well, stop the recording.
Stop.